Pharmacology questions, and we are going through 2024 quizzes. We had 4 quizzes and we'll go through all of them. Just one thing: come night, come day, come sunshine, come rains. What was meant for you can't go past your location. You are going to get what is yours. Don't worry. So, the first part is we are looking at questions that are from general topics in pharmacology. And question number one: select the most appropriate antidote or therapeutic management in each case. So, this is from poisoning and the management of drug poisoning, management of systemically absorbed lipid soluble large and highly protein binding toxins. Okay, so this one we need to know, we use hemoperfusion. Hemoperfusion is where you are passing blood. Think of the way a dialysis is, right? You are getting to remove toxins and toxic substances from blood by passing it outside. It is a bit similar. That's how hemoperfusion is. You use it for specifically large substances that are lipid soluble and those which are highly bound to proteins, because you find that it's actually very hard to remove a toxin from the body if it is bound to proteins, because things that are bound to proteins, for you to remove them, well, we're supposed to remove the protein to which they are bound, right? And those proteins are part of our bodies. They are there for normal function. So hemoperfusion is a very good way for dealing with those g- guys, especially those which are systemically absorbed, like they are throughout the body. It's very hard to remove something from a toxin that goes throughout the body. Hemoperfusion is a good method. A teenager has meted with methanol poisoning. So if someone has been poisoned with methanol, you use ethanol. It is the antidote. Poisoning caused by sustained releases or enterically coated drug preparation. So if a substance has been taken and this substance has gone to the GIT, enterically coated, you use what bowel irrigation. This is where you are cleaning the GIT, right? You clean the entire GIT to be able to remove whatever drug. And then an example of decontamination in a patient who has ingested poison. So decontamination again with ingestion. Remember, ingestion is going through the GIT, so you can wash the entire GIT. So use the whole bowel irrigation. Gastric lavage is not recommended for the ingestion of these toxins. So gastric lavage is where you are removing the contents that is which are present in the stomach by passing something through the nose or through the mouth, and then you start pulling the contents. So you don't use gastric lavage for hydrocarbons and also for compounds that are going to be acidic, which can come and then they can be inhaled, right? So you want to avoid that because they can actually cause pneumonia. You are trying to remove it, but then it can end up diverting and going into the respiratory system, because you know the respiratory system and the GIT are very near. So I want to avoid doing a gastric lavage for such. So acidic compounds, hydrocarbons. Question number two: select the most appropriate adverse drug reaction type. You can use the option more than once or not at all. Now let me just mention something. When you're talking about adverse drug reaction, the first thing we want to understand is just the same word: adverse drug reaction. Adverse drug reaction refers to a drug that is noxious or can show unintended reactions, and it normally occurs at normal dosage. So I've given you a drug. This drug is supposed to treat a headache, but then I start seeing things that are not treating headache. For example, you start having other things, or you are reacting to the drug, or maybe you are having pain. That is an adverse drug reaction. The most important thing there is that it's the normal dose that is causing unintended or noxious reaction. And then you have got toxic effect. Toxic effect is an exaggerated or an exaggeration of the desired therapeutic effect, and it is not common at low doses. So if we say a reaction is toxic or an effect is a toxic effect, it means that we have given a drug at a higher dose and then it shows an exaggerated response that is similar to the desired therapeutic effect. And this one, toxic effect, occurs via the same mechanism as the therapeutic effect. For example, I give a drug that is supposed to prevent bleeding, right? And because I've given it in higher doses, it does it all the more. You Because it is stopping bleeding, you end up, let's say, having a clot. Or let's say we give an anticoagulant, right? Anticoagulant, they stop coagulation, they stop forming of a clot, and then you end up bleeding. That is the same action that the drug was supposed to do, but then it has become exaggerated. That is toxic effect because we've given a higher dose. Adverse drug reaction, it was the same dose. And then you also have what we call side effect. Now, side effect occurs via other mechanisms and can be dependent on the dose or not dependent on the dose. Okay, so side effect is I've given a drug, but this drug, besides it, let's say I've given a tricyclic antidepressant. Besides this drug reducing depression, it can also bind on acetylcholine receptors. So I'll start seeing side effects because of the receptor that it has bound. Those are what we call side effects. Now, side effects sometimes can be beneficial because, let's say, for example, I've given a tricyclic antidepressant. Well, because it can bind on also acetylcholine receptors, the action that it will be doing on those receptors can be helpful, but that is not the intended use. So, hope we've gotten. Toxic effect is exaggeration. Adverse drug reaction is response to a drug that is noxious at normal dosage, and then side effect is occurring via another mechanism. Toxic effect was occurring via the same mechanism as the same therapeutic effect. You also have adverse effect. Please note, this is not adverse drug reaction, it's adverse effect. So adverse effect is a more preferred term because it is going to encompass all unwanted effects that we are going to see with a drug. We don't care the mechanism of action. Okay, so in adverse effect and adverse reaction, they are more the same and they are usually used interchangeably. But when we talk about adverse effect, we are referring to the drug's point of view. It's an adverse effect. What is the effect of the drug on the person? And then adverse reaction, you are looking at the patient's point of view. How is the patient reacting? That's why these terms are used interchangeably. We are trying to look at all the unwanted side effects. Okay. And then you also have an adverse event. An adverse event, this is an outcome that occurs while a patient is taking the drug, but it's not necessarily attributed to the drug that you've given. For example, you gave a drug to treat, let's say, for example, pain, right? And then the patient went to jog. They ended up injuring themselves and then they died. Doesn't mean that the death of the patient is caused by the drug that I gave. So that's known as an adverse event. And then you also have what we call pharmacovigilance, which is a science and activities related to detecting, assessing, and understanding and preventing adverse effects. That's what we call pharmacovigilance. And then there's what is known as a signal. A signal is reported information on a possible causal relationship between an adverse event and the drug. Okay, so any report that you are going to give, okay, when you give this drug, this is what to, and this can be given by the patient that was given the drug, or just the one that was prescribing the drug. Because the patient will come and report, after you gave me the drug, this is what happened. So that's known as a signal. Now, when you're classifying drug adverse reactions, you can classify them. You can use like the alphabet A, B, C, D, E, F, G. So A actually stands for augmented. Augmented, this means that you have got an exaggeration of the expected pharmacological effect. For example, when you give warfarin, warfarin is an anticoagulant. It prevents coagulation. When you give it, someone can end up bleeding. So that is a type A adverse reaction. It is augmented. It is just an exaggeration of the normal pharmacological effect. And then B is standing for bizarre, which is just an idiosyncratic reaction. It is bizarre. It is a novel response that is not expected. That's why it is bizarre. That's a type B reaction. It does not depend on the dose. For example, if you give a penicillin, someone has got an allergy. It doesn't depend really on the dose of the penicillin. All right. At any dose, someone can have an allergy. That's because of the structure of the drug itself. So that is a bizarre reaction or an idiosyncratic reaction. And then C means chronic. C for chronic. Remember A, B, C. Those are classifications of adverse reaction. So C is for chronic. Now, chronic or C adverse reactions uh, or type C adverse reactions, these are time and dose related. That's very important. For example, when you give a glucocorticoid, now you know glucocorticoids, let's say for example, you know the way cortisol is, right? You have got the hypothalamus, it is going to release uh, adrenocortical, no, not the adrenocortical releasing hormone, but the hypothalamus is going to send a signal, right? Or let me give something that is direct. So, for example, we're talking about luteinizing hormone. The hypothalamus is going to send instruction to the pituitary gland via gonadotropin releasing hormone to say, hey, we need to release luteinizing hormone. What the anterior pituitary gland is going to do is that it's going to now release luteinizing hormone and follicle stimulating hormone. Those guys are now going to go to the ovaries to cause the release of estrogen and progesterone. What happens is that when the estrogen and the progesterone increase, they are going to go back to the hypothalamus and the pituitary gland and inhibit them from producing more of the estrogen and the progesterone. So that is known as the type C adverse reaction. That's chronic. It depends on the dose. So if you have got more of the product, it can inhibit what was causing the production. For example, the inhibition of the hypothalamic pituitary adrenal system when you have got more glucocorticoid. That's the chronic or type C reaction. And then D is the delayed. Delayed, that is, it is time dependent and it's a delayed reaction. For example, when you start giving drugs to be able to treat lesser psychosis, someone can end up having tardive dyskinesia, which is a characteristic of Parkinson's disease, right? Because of the drug, but it's going to be delayed. It's after some time. And then E is meaning end of dose. So this adverse reaction happens when you withdraw the drug. That's why it's known as end of dose. For example, benzodiazepines, when you withdraw the dose, someone starts having those tremors and those withdrawal reactions, just like alcohol. And then F is failure of efficacy. So the drug undesirably starts to increase and reduce in efficacy. For example, when you give oral contraceptives together with the liver enzyme inducers, what will happen is that the oral contraceptive is going to be broken down by the liver enzyme. Let's say, for example, you've given rifampicin, which is a liver enzyme inducer, and then you give, let's say, estrogens or progesterones as to prevent pregnancy. What will happen is that because you have induced liver enzymes, those drugs are going to go, like those contraceptives are going to go to the liver and they'll be broken down, meaning that they will not show effect. Your patient will come later on and say, I'm pregnant, but ask for the drug to prevent pregnancy. Why? Because you gave a liver enzyme inducer. Okay, hope that has at least given us a clue. So, we want now to relate these statements with the type of reaction. A. Bronchospasm with non-selective beta adrenal receptor antagonist. Now you know that beta antagonist, specifically the beta 2. Beta 2 guys cause what? They cause constriction, right? That is their work. So sometimes the reaction can be a bit exaggerated or it can be augmented. It can become a bit more, right? That is type A. Remember what we said, type A, the augmented, is you are having an exaggerated response. That is a normal pharmacological effect of that drug. Okay? For example, you give warfarin, someone ends up bleeding. That's a normal physiological effect. Beta antagonist, their normal physiological effect is bronchoconstriction. That's why I'm having a bronchospasm. That is a type A reaction. And then B, the second one, sorry, aplastic anemia associated with chloramphenicol. Yeah, chloramphenicol causes aplastic anemia, but we don't know the cause. So that is a bizarre reaction. It's that type B. And then vaginal adenocarcinoma of the offspring of women taking diethylstibestro. So this is a type G reaction. I didn't talk about it. That's there is genotoxicity. When it comes to cancers, so there is some genetics that has caused or that has even worsened the proliferation of the vaginal epithelium causing this cancer. So that is some genetics. That's a type G genotoxicity. And then a Japanese patient who is rapid acetylate due to genetic variation is given standard dose isoniazide. So this reaction, this is a Japanese who is rapid ace- acetylate due to genetic variation is given standard dose isoniazide. That's type F. It's unexpected failure of efficacy. Okay, the Japanese guy is given standard isoniazide, but you can see there is a genetic variation. So we couldn't expect this. Okay, you can't really differentiate. You have got two people, or let's say 10 people, which are coming from the same environment. When you give them the drug, some the drug is working, others the drug is not working. Genetic variations are unexpected, right? So that is type F. And then hypothalamic pituitary adrenal axis suppression by prolonged administration of glucocorticoid. Remember, we said this is chronic. Type C, when you give more of the glucocorticoids, they go and inhibit what was causing the production. Antiemetic action is produced through 5-HT4 agonist, H1 agonist action, olfactory apparatus stimulation, and you also have D1 antagonism. Yeah, so that is the serotonin receptor, the first one. When you are talking about emesis, that's vomiting. It's a very nice phenomenon. So what should you understand there? Vomiting, for it to happen, there are a lot of receptors that are involved. Right, a lot. So I've got what we call the chemoreceptor trigger zone, and the chemoreceptor trigger zone can be triggered by a lot of things to cause emesis. And so serotonin is one of those things that can be able to stimulate uh, the chemoreceptor trigger zone so that someone can end up vomiting. Besides that, acetylcholine can also stimulate the chemoreceptor trigger zone. Besides that, you can also have dopamine. So all those drugs, you can stimulate the chemoreceptor trigger zone, and then they are going to end up stimulating the vomiting center. When we stimulate the vomiting center, that's when now someone will be able to vomit. Okay, so hope that makes sense. So let me just give a short thing for us to know. So different substances, as we've said, they can stimulate vomiting. They can stimulate the vomiting center. Others will first stimulate the chemoreceptor trigger zone, and then they'll stimulate the vomiting center. The cerebral cortex itself can stimulate vomiting. Like if when you just smell something bad, you see something bad, you think, or maybe you anticipate vomiting. The cerebral cortex can stimulate vomiting, right? And then uh, chemicals and radiotherapy can as well stimulate vomiting by stimulating the pharynx and the GIT, and also serotonin receptors, and also motion sickness. Motion sickness is because of disturbance in the vestibular nucleus. So you have got the muscarinic receptors, they are the M1, and the histamine receptors, the H1 receptors. So those guys can be stimulated by the vestibular nucleus. That's what is known as motion sickness. Like when someone is traveling, you feel like vomiting. And then you also have chemotherapy, opioids, right? Anesthesia. This guy can stimulate the chemoreceptor trigger zone, where I've got the serotonin receptors, 5H2, H3, 5TH3. You also have dopamine D2, opioid receptors, and the substance P. All these receptors can stimulate the vomiting center to cause vomiting. Okay, so hope we've gotten that. So we are saying 5-HT4, right? Which of the following is beneficial in NSAID-induced gastric ulcers? Gastric ulcers, you know, they can be caused by people that by H. pylori, NSAIDs, even just anything that causes a stress, and you know, stress causes the production of acid. Let me tell you kama something. When it comes to peptic ulcers, you have got duodenal and gastric ulcers. Gastric, think of the stomach is on top, right? Gastric ulcers is more associated with people that have got blood group A, and then duodenal ulcers, those with blood group O. So for NSAID-induced gastric ulcers, you can use misoprostol, which is a prostaglandin E1 agonist. It's the best that you can use for that. Ondansetron, this guy is going to be used in ondansetron is going to be used as an antiemetic, prevents vomiting, and it specifically works via the serotonin 5-HT3 receptors as an antagonist. You're seeing the difference with the equation on top here? This was talking about agonist. So if you agonist of 5-HT4 will produce antiemetic action. This is 5-HT4. These are agonists. Otherwise, for antagonists, it is 5-HT3. That's a difference we need to take note there, like ondansetron. The most effective antiemetic for controlling C-plastin-induced vomiting is, so ondansetron, the same one, the antagonist for 5-HT3 is going to prevent this C-plastin-induced vomiting. Which of the following is not used for H. pylori treatment? Now, in H. pylori treatment, this is the guy that causes peptic ulcers. You can use amoxicillin because it's an antibiotic and this is a bacteria. Bismuth compounds, these are ulcer protective. These are going to be protecting the wall of the stomach or the GIT from the acid. Omeprazole is a proton pump inhibitor. It's going to protect, but oxytetracycline is not used. Which of the following drug is not used for motion sickness? Cyclizine, this is used for motion sickness. Metoclopramide is okay. We want what is not used. Cyclizine is used for motion sickness. Scopolamine is used for motion sickness. It also has got another name. And then you also have cynarizine is also used for motion sickness. Just something a bit quick. When you're talking about drugs used for motion sickness, you have got those which are going to be binding to the D2 receptors, because D2 receptors, when dopamine binds to them in the chemoreceptor triggers and they'll stimulate vomiting. So a D2 receptor antagonist can inhibit vomiting. For example, domperidone and the metoclopramide will block the D2 receptors in the chemoreceptor trigger zone, and so they can be used to prevent vomiting. Okay. And you also have other prokinetic action. So prokinetic drugs which are going to be working by inhibiting the not inhibiting but acting as agonists on the 5-HT4 receptors. And then other drugs that we can consider is the chlorpromazine and the droperidol. These are also D2 receptor antagonists. You also have those drugs that are going to attach to the neurokinin 1 receptor to antagonize it. And then you also have H1 receptor antagonist. You can see antagonist, not agonist. H1 antagonist. For example, you have got the meclizine, cyclizine, promethazine, and the diphenhydramine. So those guys are H1 receptor antagonists. They will also be used as antiemetics. And then you also have those which are going to antagonize the muscarinic receptors. That's why I've got this scopolamine, which is also known as a hyoscine. You also have glucocorticoids. Glucocorticoids like dexamethasone. Where do you remember dexamethasone being used? Okay, you remember it in asthma. And methylprednisolone. These glucocorticoids can as well be used to prevent vomiting, especially in chemotherapy induced vomiting, the vomiting that comes after chemo. These guys will bind on the 5-HT3 receptors and then antagonize them. And then, next question, stimulant purgatives are contraindicated in the following. All the answers before abdominal radiotherapy, subacute intestinal obstruction, bedridden patients. So stimulant purgatives, you don't want to use them in people that have got subacute intestinal obstruction, right? M1 blocker used in peptic ulcer disease, atropine, pyridostigmine, oxybutynin, perenzepine. Okay, here we need to know this guy really. Perenzepine is the M1, is the guy that will block the M1 receptors to prevent peptic ulcers. Which of the following laxative lower ammonia levels in hepatic encephalopathy? Lactulose, liquid paraffin, bisacodyl, magnesium sulfate. Now, hepatic encephalopathy, what happens is that the GI tube has got bacteria. Bacteria, when it breaks down their food, it can produce ammonia. So if the liver is not working, what is going to happen is that ammonia is going to start accumulating and it can go to the brain and start causing neurological symptoms, and that's known as hepatic encephalopathy. So to prevent that, you can use lactulose. Okay, it will lower the blood ammonia. Which antiemetic drug selectively blocks levodopa-induced vomiting without blocking its anti-Parkinsonism action? Domperidone. This guy is going to selectively block levodopa action without blocking its anti-Parkinsonism action. Remember, levodopa is a drug that is used in Parkinson's disease. So it means that if you give levodopa, so if you give a drug that can inhibit levodopa, you expect it to what? To prevent also its Parkinsonism action. But then when you give domperidone, it's an antiemetic, it will block levodopa induced vomiting, but it won't prevent its Parkinsonism action. So where levodopa works to prevent Parkinsonism, it will not affect that place. It will simply go and prevent the action that it shows on vomiting. A patient with variant angina started treatment with isosobide, mononitrate, and diltiazem. Which of the following actions most likely mediated the therapeutic effect of nitrates in the patient's disease? So this patient has got angina. Angina is caused by no enough blood supply to the heart. Maybe there is a blockade. I've got different types of angina, stable angina and stable plasmentals. So what this drug is going to do, the nitrates are going to do in helping angina, is that they are going to increase blood flow in the epicardial vessels, because that's a problem. You don't have enough blood going in these vessels. A 67-year-old woman received hydrochlorothiazide for 1 month to treat her recently diagnosed essential hypertension, developed hypokalemia. Which of the following actions most likely contributed to the thiazide-induced increase in renal excretion of potassium? Increased sodium load in the lumen, blockade of sodium potassium chloride, co-transporter thiazide-induced decrease in renal secretion of uric acid, stimulation of sodium potassium pump. Now here you have got this woman. This woman is taking this drug for 1 month. They've been diagnosed with hypokalemia, essential hypertension developed hypokalemia. Now you want to tell the most likely action that led to having this hypokalemia in someone that is taking thiazides. Now thiazides actually inhibit the sodium chloride pump. Okay, sodium chloride pump. So what is going to happen is when you inhibit this pump, there's going to be increased sodium load in the lumen, because when you inhibit this pump, what happens is that sodium cannot be uptaken in the distal convoluted tubules. It can't be taken back into blood, so you are going to be excreting it, and as you excrete the sodium, you're also going to be excreting what? You also be excreting the water. And so you are reducing the blood pressure. The thiazides are inhibiting this sodium chloride pump in the distal convoluted tubules. A woman who has been suffering from stage C heart failure was on captopril, furosemide and digoxin for 2 months, which controlled her disease. She developed a third-degree AV block due to digoxin therapy. So the following would be an appropriate therapeutic adjustment for this patient. Now, you know this patient has got heart failure. Of course, digoxin is going to be helping because it's a sodium potassium pump blocker. As it is doing that, it can cause a third degree heart block. So I want to give another drug that will go by another mechanism. So that's why we're going to discontinue digoxin and start miorilon because it's going to take another mechanism to help in concerning the action or effect of diuretics. Furosemide inhibits renal prostaglandin thiazides. Diuretics inhibit sodium chloride cotransporter. Acetazolamide increases bicarbonate. Mannitol increases sodium ex- uh, s- mannitol inhibits sodium potassium chloride co-transport in the loop of Henle. Okay, so the first option, furosemide, also known as the furosemide, does not really inhibit renal prostaglandin. Instead, it is an inhibitor of the sodium potassium chloride co-transporter in the thick ascending loop of Henle. That's the mechanism of action. Okay, so it doesn't inhibit prostaglandins. And then B is correct. As we said earlier, thiazides inhibit sodium chloride co-transport in the distal convoluted tube. Acetazolamide, this one is going to inhibit it's a carbonic anhydrase inhibitor and not increasing bicarbonate. Okay, so actually when it inhibits the carbonic anhydrase enzyme, it is going to lead to decreased reabsorption of bicarbonate in the proximal tubules. And so it is going to lead to increased excretion of bicarbonate instead of increased bicarbonate in blood. And then mannitol is an osmotic diuretic. So it is going to increase the osmolarity of the filtrate in the renal tubule. And when you increase the osmolarity, to mean that water will start coming in the renal tubules and leading to excretion of water, right? So you can go to the next question. A 50-year-old man with a long history of heart failure was admitted with severe generalized edema with respiratory distress. You can see those symptoms are symptoms of left-sided heart failure. The glomerular filtration rate is 20 mL per minute. Which of the following directives would be appropriate to relieve the edema in this patient? Every time you're talking about relieving edema in heart failure, always think of loop diuretics. Loop diuretics. That's very important, right? Because when you look at the other options like spironolactone, this one is going to be used to treat conditions, of course, like heart failure, hypertension, and also edema that is associated with liver cirrhosis. Which of the following diuretics correctly match the given clinical indication? Furosemide, angionephritic edema, spironolactone, myoxedema, hydrochlorothiazide, diabetic insipidus, trienterine, papilledema. So starting with a furosemide or furosemide, this one is used to treat edema associated with congestive heart failure where both the right and the left heart is failing. That's the treatment. Besides that, you can also use it in liver cirrhosis and renal disease. It is a diuretic, as we said, right? Inhibiting the sodium potassium chloride pump co-transporter. Spironolactone, this is a potassium sparing diuretic and is going to be used, as we said, for heart failure, hypotension, and edema associated with liver cirrhosis. Because if the liver is failing, there can be edema, isn't it? Because let's say contents of blood will not be able to pass from the portal vein to the liver, and so it will end up moving out of the blood vessels. Not myoxedema. And then hydrochlorothiazide, yes, this is of course true. It is going to be used to treat diabetic insipidus by reducing urine output and increasing urine concentration. Because this guy, conditions where someone is urinating very much, so this one can be given hydrochlorothiazide to reduce urine output and increase urine concentration. Trienterine, this guy is used to treat edema that is associated with congestive heart failure and also liver cirrhosis and nephrotic syndrome, not really papilledema. Papilledema is where you are having the swelling of the eye because of the meninges swelling. A man with severe cardiac failure is started on treatment with propranolol, saptopril, and digoxin. Diuretic therapy is also included. Which of the following pairs of diuretics would be most appropriate to use in this patient? Okay, remember this patient has got what? They have got cardiac failure, they have got heart failure, and you have given them these drugs. And you also need to include a diuretic. So what should you use? You want to use the furosemide and spironolactone. And the reason you want to do that is because furosemide is a loop diuretic, right? And it is actually good when it to be able to reduce fluid overload that is caused uh, in this patient that has got heart failure. Remember, heart failure, there's going to be fluid accumulation either in the lungs or in the periphery. That is what is leading to the edema. Spironolactone is a potassium sparing diuretic that is able to help prevent uh, hypokalemia, right? Because when you give furosemide, it doesn't spare potassium, so it can lead to hypokalemia. So you can also use the spironolactone, which is a potassium sparing, so that it can prevent hypokalemia that is caused by the loop diuretics. So that is that. A patient with a 3-week history of angina was discharged from the hospital with a prescription of nifedipine, which action most likely mediated the drug's therapeutic effect in the patient's disease. So how does the nifedipine work? So nifedipine would decrease coronary vascular tone. How this guy works is that it is a calcium channel blocker. So it is going to be able to relax the blood vessels. And when it does that, it is relaxed them, right? It has decreased the coronary vascular tone. It has decreased the tone. A hypertensive patient is 2 weeks pregnant. Which of the following antihypertensive drugs class is absolutely contraindicated in this woman? So hypertensive who are pregnant, you should never use ACE inhibitors, angiotensin converting enzyme inhibitors, okay? Because they can cause serious fetal risks. For example, intrauterine growth restriction, neonatal renal failure, and also oligohydramnios, and even fetal death. So never use ACE inhibitors. A patient has striking a patient has striking hypertriglyceridemia after about 6 months of drug treatment is triglyceride and very low density lipoprotein cholesterol levels dropped dramatically, and his high density lipoprotein cholesterol levels doubled. This phenomenon is commonly associated with nicotinic acid, niacin, vitamin B3, all those names, it's the same thing. Is very good in reducing both the bad cholesterol and increasing the good cholesterol. It is the best in treatment. It's the best. It's just that it's avoided because of some fewer limiting adverse effects like flushing and those which can of course be prevented by aspirin, giving aspirin 45 minutes before. Which of these is not an action of angiotensin converting enzyme inhibitor on the cardiovascular system? They reduce peripheral vascular resistance. They are going to do that. You know what happens? As inhibitors, what when you give them, what is going to happen is that they are inhibiting the angiotensin converting enzyme, right? And when they do inhibit the angiotensin converting enzyme, what they do then is that, let me explain it in this way. These guys are loop diuretics, isn't they? Are diuretics, not loop diuretics. It's a class of diuretics itself, ACE inhibitors. You are removing fluid. When you remove fluid from the body, you have got little fluid that remains. What happens? There's little resistance. They also improve the left ventricular systolic function. It will cause the left side of the heart to pump more. They also reduce preload. Actually, what happens is that when you've reduced fluid, you've reduced the preload. The fluid that is coming back to the heart has been reduced. Okay? And they also reduce afterload. If what is come to the heart is small, what can go out of the heart is also small. So they will also reduce afterload, not increase afterload, because they are leading to loss of fluid. A black woman with stage 1 essential hypertension started treatment with thiazide diuretics, which of the following molecular mechanism is more likely to mediate the long-term antihypertensive of effect of the thiazide diuretic. Remember, this is a patient and it's good, it's a black woman. Actually, thiazides are very good in hypertensive disease for black people. So what is the mechanism of action? As we said earlier, thiazides will be able to decrease sodium in smooth muscle cells because it actually inhibits the sodium chloride pump in the distal convoluted tubules, leading to the loss of sodium. So it will be able to decrease sodium in the smooth muscles. You know the blood vessels are surrounded by smooth muscles, isn't it? Which of the following is an expected effect of glucocorticoids? Glucocorticoids, number one, they will is not an expected effect. Glucocorticoids will increase the excretion of nitrogen, so not decrease. So that's why it's not correct. They will increase the liver glycogen. Like this is a glucocorticoid. What they will do is that they are going to stimulate uh, the synthesis of glycogen. They also decrease sensitivity to insulin because, like, it's a glucose. You want glucose in the body. This is a glucocorticoid, right? And then they also include the increase in blood glucose levels. Yes, that's true. They increase blood glucose levels. The blood glucose levels increase, there's decreased sensitivity to insulin, because if it was like if if blood glucose levels increase and there's no sensitivity to insulin, it means that there is sensitivity to insulin. It means that the insulin would remove the glucose from the blood and take the glucose into the cells. But because of the decreased sensitivity to insulin, that's why there's an increase in blood glucose levels. When the blood glucose levels increase, some of that insulin that is the glucose that's present in the liver can now be used to make glycogen. 53-year-old woman complained to a physician of weight gain, mild but continuing facial acne, and pigmented striae on her abdomen. Further examination leads to the diagnosis of Cushing's. Which drug would be the most appropriate to treat this condition? Now, the characteristics which have been described, of course, are describing Cushing's disease or Cushing syndrome, where you have got a lot of cortisol. And when you have got a lot of cortisol, that's the one that causes the striae in the abdomen, acne, weight gain. Okay, so all those are the functions. And ketoconazole, which is an antifungal drug, is actually a very good medication when it comes to helping in Cushing's disease. A 26-year-old man wishing to start a family was diagnosed with infertility because of oligospermia. He started a treatment that induced intramuscular injection of human chorionic gonadotropin 3 times weekly. Which of the following molecular actions is the intended target of the therapy? Now, human chorionic gonadotropin has got a similar effect of, what happens is that when you have got luteinizing hormone, like the hypothalamus is going to release sorry, not that one, gonadotropin releasing hormone to stimulate the anterior pituitary gland to release luteinizing hormone and follicle stimulating hormone. These hormones are now going to go to the gonads. In the male, luteinizing hormone is going to stimulate the Leydig cells to start producing sperm, testosterone. So the same function of luteinizing hormone is the function for human chorionic gonadotropin. That's how it works. Okay. So the answer is stimulation of Leydig cells, testosterone production. The drug of choice in Addison crisis is spironolactone, dexamethasone, hydrocortisone, ketoconazole. So what is really the issue when it comes to Addison's crisis? What is the problem here? So you have got overproduction of these mineralocorticoids, like the cortisol. There is too much cortisol. So you can give hydrocortisone. If you give this one, it's going to send a negative inhibition on the hypothalamus and pituitary gland, and then you are going to have a reduction in the production of the cortisol. Prolonged overdose of hydrocortisone can cause all of the following except. Remember, hydrocortisone is more like increasing cortisol. It can cause all the following except osteoporosis, mental depression, thickening of the skin, slow healing of wounds. Thickening of the skin is not an effect. Weakening of the bone, osteoporosis is going to be caused. Mental retardation, yes. Amitriptyline for a woman with primary amenorrhea. Normal menstruation returns about a month after starting therapy. Which of the following statements best describes the mechanism by which bromocriptine causes this effect? Now we have got what is known as the tubero-infantibular pathway. This is a pathway that comes from the hypothalamus to the pituitary gland. It's a dopaminergic pathway, and bromocriptine is actually going to bind on the dopamine receptors, D2 receptors. When it binds to those receptors, it's going to because what happens is that when you have got dopamine in the tuberoinvertebral pathway inhibits the production of prolactin, because prolactin comes from the anterior pituitary gland. So when dopamine is released from the hypothalamus, goes into the tuberoinvertebral pathway and binds to the D2 receptors, it is going to inhibit the production of prolactin. When prolactin is being reduced, prolactin, what it does is that it inhibits the production of estrogen. So if you inhibit it, it means that estrogen will be produced. And so there will be now normal menstruation, because inhibition of estrogen is what causes the amenorrhea. So bromocriptine inhibits prolactin release. Clinical uses of octreotide include all the following except acromegaly, thyroid stimulating hormone secretion adenomas, bleeding esophageal varices, endometriosis. Okay, so this guy, acreotide, is going to be used in acromegaly, where you have got increasing bone density, thyroid stimulating hormone secretion adenoma, bleeding esophageal varices, but not endometriosis, the inflammation of the endometrium. A 49-year-old woman was admitted to the hospital because of foot tetanic, muscle spasms, and palethiasis following a recent thyroidectomy. Which of the following drugs given IV could rapidly reverse the patient's symptoms? Remember, this patient, the thyroid gland was removed. What the thyroid gland does is that it has got C cells which produces calcitonin. Calcitonin is going to come and wake, because what happens is that when you have got high calcium, calcitonin wants to lower the calcium. When you have got low calcium, the parathyroid gland produces parathyroid hormone, which is supposed to increase the calcium. So in this case, because we've removed the thyroid gland, it means that there's no proper calcium regulation, so you can give calcium gluconate. Okay. So next question, which of the following matches the action and clinical indication correctly? Nandrolone, androgen receptor antagonist, benign prostatic hypertrophy, anastrozole, aromatase inhibitor, breast cancer, flutamide, androgen receptor agonist, male hypogonadism, levonorgestrel, estrogen receptor agonist, hirsutism. Now, just something that we need to know about these drugs that we use, the sex hormones that we use in the treatment of these different conditions. To start with, for androgens, androgens, these are like estrogens, progesterones. These drugs are going to be used in conditions like, because estrogen and progesterone, they are necessary, and testosterone for the males, for the secondary characteristics of the males and females. So for the androgens, when you give them, their uses are hypogonadism, delayed puberty, and also breast cancer in palliation. Okay, so those are the many important functions. So drugs that will be acting as agonists to the androgens will be doing these same functions. And then you also have other steroids which are known as anabolic steroids. When you give these drugs, what they do is that they have got more effect on making increasing body mass. For example, nandrolone or xandrolone. So such drugs, known as anabolic steroids, they can be used to stimulate growth and increase muscle mass in general muscle wasting, aplastic anemia and such. And then androgens, those which are against androgens, which prevent the synthesis of the androgens or maybe the binding of the androgens. You have got drugs like ketoconazole and type 2 5 alpha reductase inhibitors. These drugs, what they do is that their general functions is to be used in male hypersexuality, where there is too much sexuality, prostate cancer because the prostate has become big due to a lot of hormone, and also hirsutism in females because it means that for you to develop hairs there is too much of the hormones, isn't it? So these drugs will include drugs like, for example, finasteride, steroid. Now, I don't want us to master really that, but I want us to relate that. So starting with A, nandrolone androgen receptor antagonist, benign prostate hypertrophy. Of course, if it was an antagonist, androgen receptor antagonist, yes, it would be used in benign prostate hypertrophy. That is true. But then androlone is uh, nandrolone, sorry, is not an androgen receptor antagonist. Remember, I mentioned it as an anabolic steroid. So that's why it's not correct. Anastrozole is an aromatase inhibitor. It's used in breast cancer. Yes, that's true. Because aromatase is an enzyme that is going to be used in making the estrogen, and estrogen is very important when it comes to the development of breast cancer. If you inhibit the production of estrogen, you are going to reduce the risk of breast cancer. Flutamide androgen receptor agonist, male hypogonadism. Okay, so flutamide is, of course, if it was an agonist, it would be used in male hypergonadism, but flutamide itself is an antagonist, not an agonist. And then levonorgestrel is a receptor agonist, isotism. Now remember we said that in isotism we use what? Antagonist, not agonist. Of course, levonorgestrel is an agonist. Okay, so that's why it's not an answer. Which of the following corticosteroid is devoid of glucogenetic action? Prednisolone, dexamethasone, cortisol, or desterone? Now, these guys, these cortisol, dexamethasone, progesterone, they have got also an effect on glucose. Okay, glucocorticoids. Remember, all glucocorticoids are corticosteroids, but not all corticosteroids are glucocorticoids. Aldosterone is not going to have effect on glucose, the making of glucose. 42-year-old woman recently diagnosed with lupus erythematosus started treatment with high daily dose of prednisolone. The woman had a history of type 1 diabetes, currently controlled with 2 daily administration of premixed insulin. Which changes in the patient's antidiabetic regimen should be made now? Add D-sitagliptin to the antidiabetic regimen, add exenatide to the antidiabetic regimen, add the glimepiride to the antidiabetic regimen, increase daily insulin. So what's happening is this person has got systemic erythematosus, lupus, and then you start treating them with the prednisolone, and you know that this is a corticosteroid, right? It increases glucose in the body, and then this patient has got type 1 diabetes where you are trying to treat the glucose. So what should you do? Should you stop giving them the drug which is increasing glucose? Not really. Just give the drug that is helping diabetes in high amount. Okay. Remember the problem is because this is type 1 diabetes. There's no other drug that we can use except insulin. These other drugs, exenatides and these others, are used for type 2 diabetes, not type 1. Type 1 you can only use insulin. So you just increase the dose of insulin. Chronic kidney disease may result in secondary hyperthyroidism due to calcium deficiency. One of the treatment includes synacetate, which may reduce bone demyelinization from constant parathyroid hormone release. Which of the following describe mechanism of action of synacetate? Okay, so that one block parathyroid hormone receptors, activate parathyroid hormone receptor, block calcium sensing receptor, activating calcium sensing receptors. So that's the mechanism. This drug is going to activate calcium sensing receptors. Remember what parathyroid hormone does? And that's the problem that is described here. Someone has got chronic kidney disease, which can result in secondary hyperthyroidism. Because what happens that when the calcium reduces, what happens is it stimulates the production of parathyroid hormone. Parathyroid hormone is going to go to the kidney to cause the kidney to reabsorb calcium. Besides that, it's going to cause the kidney to activate, is going to activate alpha 1 hydroxylase in the kidney to cause the activation of vitamin D to the active form of vitamin D, which is 1,25 dihydroxycholecalciferol, which is also known as calcitriol. And that calcitriol will go to the intestine to cause the absorption of calcium from the food. PTH, parathyroid hormone, also has got an effect on the bone to cause the breakdown of the bone. Okay, so in a case when you are giving this drug, is going to increase, is going to activate calcium sensing receptors to be able to increase the calcium sensing receptors like that, and instead of any other effect.